The high-risk MDS field remains an area of major unmet need. For the last 20 plus years, we've only had approval of the HMAs, azacitidine, decitabine. Numerous drugs have been evaluated in this space, combined with azacitidine, such as Revlimid, Vorinostat, and others, and we've seen multiple negative results. And 5 drugs have recently been evaluated in the frontline setting, combined with azacitidine. 2 of these have read out. APR combined with azacitidine TP53 mutated MDS unfortunately did not meet the primary efficacy endpoint of CR. Although there was a benefit, it did not meet the statistical requirement. Azacitidine Venetoclax versus azacitidine placebo also did not meet the primary endpoint. But the other studies that are ongoing include drugs Magrolimab, Venetoclax, Sabatolimab. We're especially quite excited about both Venetoclax and Magrolimab. These have now quite a good number of patients with follow-up mature data both in MDS, AML, and of course Venetoclax has already been approved in frontline AML. The data in MDS frontline looks very encouraging, high response rates, CR rates, good tolerability, and similarly for azacitidine Magrolimab. So they are both in randomized studies, which in the next year and a half we should have data, and we're hoping both of the drugs could get approved. And then the question will be, do we select patients based on their underlying mutation? For example, IDH1, IDH2, SRSF2 respond very well to Venetoclax-based therapies in AML and probably in MDS, whereas TP53 secondary MDS adverse cyto respond well to Magrolimab. And so we could select patients based on their underlying cytogenetic molecular profile as well as fitness and tolerability. But then also we would evaluate the combination of the azacitidine, Venetoclax, Magrolimab in MDS. So we have to wait to see what happens, but we're hoping both those studies will be positive and we should know soon.